hope that they will definitely attend the class. Bismillahirrahmanirrahim. Today I first of all welcome all of you to a PhD program in the Department of Physiology and Biochemistry. We will study in this subject especially the advanced physiology of kidney and sweat gland. There will be one practical in a week and 2 theories in which we have to conduct the contents. We have to cover the contents of a syllabus. So we will discuss over here because this is the first practical class. So we have under this subject to learn the techniques of for determination of glomerular filtration rate and conducting the renal clearance studies, urine analysis and dialysis. So today this is the urine analysis is one of the practicals which we are conducting even in a first prof DVM in second semester. So before we may have to proceed, I have to tell you that there are 2 theories which will be conducted on Monday. One is from 8:30 to 9:20, and then another theory is 11:10 to 12 noon on Monday. Whereas there is only one practical which will be conducted from 8:30 to 10:10, which is going to be conducted on the Wednesday as I am conducting today. So this will be the regular practice that we may have to conduct the practicals on a Wednesday and conduct the theory classes on Monday. So they both are the theory, first theory and the first practical. They all are on early in the morning from 8:30 to 9:20 theory and 8:30 to 10:10 practical. तो इसका मतलब ये है कि 8:30 बजे से 9:20 तक जो है ना थ्योरी होगी मंडे के दिन, और फिर 11:10 पे थ्योरी स्टार्ट होगी और 12 बजे ख़त्म होगी मंडे को. तो ये 2 थ्योरीज होंगी प्रैक्टिकल इसमें एडवांस फिजियोलॉजी ऑफ किडनी एंड स्वीट ग्लैंड के लिए, और एक प्रैक्टिकल होगा जो वेडनेसडे को होगा, और ये रेगुलर एवरी वीक प्रैक्टिस होगी. जो कंटेंट्स हम स्टडी करेंगे फॉर थ्योरी, हम पढ़ेंगे ग्रास एनाटॉमी of the kidneys and urinary system. We will discuss the nephron, its component, nephron tubules and ducts, and the juxtaglomerular system, control of renal function, glomerular filtration rate, formation of filtrate, nature of filtrate, factors influencing filtration, formation of urine by the kidneys, tubular function, and plasma, clearance, tubular reabsorption, sodium reabsorption, glucose and amino acid reabsorption, transport of water and non-absorbed solutes, reabsorption of protein and peptides, tubular secretions and the glomerular tubular balance, maintenance of extracellular fluid hydration, concentration of urine, antidiuretic hormone, kidney regulation of extracellular volume, and de-electrolytes renin-angiotensin aldosterone system maturation, characteristics of urine and renal clearance, kidney function in birds, physiological anatomy of sweat glands, secretion, and its regulation by anatomic nervous system, mechanism of sweat secretion, acclimatization of sweating mechanism, factors influencing sweating. So these will be the contents of the theory, which will be covered in this semester, and 2 classes of each theory will be conducted in a week. Whereas we have to do the practicals, the techniques for determination of glomerular filtration rate, and conducting a renal clearance studies, then urine analysis and dialysis. For this purpose, we have the books to be referred. One is the Nephrology and Urology of Small Animals by Joe Burgess and David Paulsen. First edition 2011. William Blackwell is the publishing company. The another book we can refer that will be the Canine and Feline Nephrology and Urology, second edition 2010 Saunders, and we can even go through for a reference the Duke's Physiology of Domestic Animals by William Rees, Howard and Rickman, Jess and Goff, Istro and Humiria, 13th edition of this book, Duke's Physiology of Domestic Animals of 2015. So William Blackwell is the publishers. So these are the contents and the books to be referred are recommended for the syllabus. Now we are proceeding towards our practical. Today's practical, I hope that the student must join today, and therefore uh, we may have to go through this practical. This first slide is showing that it's my introduction, especially that I am recording all these practicals and theories uh, on this team, Microsoft team, and then I have launched that one, disseminate that one for studying it, and the students repeatedly watch these slides and presentations and lectures. Then they are revising their courses. So I am uploading this lecture on my YouTube channel, which I have established for the students from last I'm launching these lectures and practicals on my YouTube channel, which is launched in 2005, and then continuously I'm launching every informative lecture or even the cases which I'm observing in the field. They are being also disseminated for the information and the learning of the students and my colleagues. So they may have to refresh their experiences, and by sharing my experiences and even my notes and lectures on the YouTube that have to serve for coming batches as well. And the last year, which I have shared the lectures, today these lectures are helping and assisting and providing the notes and the presentations to the present students of the first year. It's second year and even to the students of a MPhil and a PhD. So now these lectures will be also available on the my channel, that's www.youtube.com/users Kashiwal 2003. If you are interested to watch all these lectures of the first year student, MPhil student, PhD students, you may have to subscribe this channel, and the new things and informative thing material may be disseminated by me in the future that can be notified on your after a subscription, and you may have to receive my notifications on your mobile, on your laptop, and then you can watch these channels, these presentations and lectures. I have given over here the email address. That's one is the official email address, and other is the general and a common. Both are functional, and I'm receiving every day the emails, and I go through those emails and reply them. If you have any conversation, any communication, any material to be shared with me, or any query which has to be related with my presentations and notes and lectures, or any material which you require, which might be present with me, that can be shared with you on through these emails. Whereas the WhatsApp number for a common use that I'm using it from 1991 to today, this WhatsApp number is available for communication uh, for any message or any communication related to the lectures related to my uh, practical life or a professional life. You can even consult with me for contact on my WhatsApp number. So now we are starting to discuss the urine analysis. What's urine analysis, how to do that one, and why we are doing. So urine analysis is being indicated when there is a suspicion of a renal diseases like glomerulonephritis, nephro syndrome, pyelonephritis, and renal failure. Detection of urinary tract infection, detection and management of metabolic disorders like diabetes mellitus, differential diagnosis of a jaundice, detection and management of a plasma cell dyscrasis, diagnosis of a pregnancy. So urine analysis can be done for the disease detection or even for the pregnancy diagnosis. In the composition of a normal urine in a human, we can see the volume that might be from a 600 to 2000 ml, which may vary in animals from species to species. So the DR for the urine DR needed that we must have the reference values for comparison of or for diagnosis of the diseases. So in the human, we have a references which can be compared with the sample, and then can be diagnosed. Any difference in it and fluctuation may have to lead the suspicion of the disease and confirmation of the disease, as well as if we want to diagnose the pregnancy, that can be even diagnosed through a urine analysis by determination of a progesterone level in the urine. A specific gravity, that's always mean 1.003 or 1.030. Osmolarity is a 300 to 500, whereas the pH is 4.6 to 8 in the urine. That can vary that might be acidic nature or that might be alkaline in pathological conditions. Whereas it may have to leave acidic, more acidic if it is a pathological, and more alkaline beyond that if it is uh, any pathological condition in the animals. Whereas the fluctuation of a pH from 4.6 to 8 is normal. It depends again on the diet which is taken by the human being. Glucose is 0.5 grams, protein is 150 mg, whereas the urobilinogen is 0.5 to 4 mg. Phosphobilinogen is 0 to 2 mg, whereas the creatinine is a 14 to 26 mg per kg or 11 to 20 mg per kg in a woman. So 14 to 26 mg per kg in a man. So urea nitrogen is 12 to 20 mg grams, whereas uric acid is a 250 to 750 mg, whereas the sodium is a 40 to 220. The potassium is a 225 to 125. The chloride is 110 to 250. The calcium is 50 to 150 mg, whereas the glutamic acid is less than 3 mg, whereas the red cells, epithelial cells, and the white blood cells that might be a 1 to 2 or a higher power field may have to show you these cells. So this is the normal composition. If you found the concentration within these ranges, then the urine is normal. The collection of a urine, we must have to collect the urine first in the morning. That must be a midstream prepared for the routine urine analysis. Whereas the random can be collected at the midstream routine urine analysis. First morning midstream clean catch bacteriological examination, post-periodial estimation of a glucose or urobilinogen 24 hours after the quantitative estimation of a protein and hormones, catheterized sample for a bacteriological examination in infants or bedridden patients and in obstruction of the urinary tract. So catheterization can be performed in the infants which cannot urine themselves, or the patients which cannot normally urine, which having bedridden patients, or even the having a retention of a urine or obstruction in a urine, that the urine sample can be collected by a catheterization. Whereas in the animals, mostly in the small animals, we can collect the urine by a catheterization. Plastic bag or a colostomy bag tied around the genitals are infants, incontinent adults. So we may have to tie up the bags by a colostomy and then collect the samples from the plastic bags to analyze the urine. Changes which in standing urine are room temperature when we are collecting the urine. So increase in pH due to a production of ammonia from urea by urease producing bacteria. If we are placing the urine sample in a room temperature, so the pH can be increased, because if there is an infection in the urine, so it may causes to increase the pH. So you must have to analyze for a pH immediately the samples when you are placing it on a room temperature. formation of crystals due to a precipitation of phosphates and calcium, making the urine turbid. So if the urine is transparent and you are keeping it on a room temperature and it is going to be turbid, it means that the crystals due to a precipitation of phosphates and calcium, they made it. So therefore, the this for those samples which having a phosphates and a calcium crystals that may be analyzed, and for the determination of crystals, it should be processed immediately. Loss of ketone bodies, since they are volatile, though ketone bodies can be lost if the urine is being kept at a room temperature for a longer period. Decrease in the glucose due to a glycolysis and the utilization of a glucose by cells and bacteria. If we are keeping the urine on room temperature, it may have to lose the glucose concentration because of the glycolysis and utilization of the glucose by the cells which might be present in the urine and the bacteria. Oxidation of a bilirubin to a biliverdin, causing the false negative test of the bilirubin. So it may have to misguide you if you are keeping the urine sample in a room temperature at a room temperature. It may causes oxidation and gives you the uh, bilirubin test false negative because of the oxidation. So the oxidation of urobilinogen may have to urobilin causing a false negative test of urobilinogen because of the oxidation. So bacterial proliferation may have to lead, and it may have to show you a more infection rather than the having a less infection, which may be because of keeping the urine sample in the room temperature. It may have to lead towards the proliferation of the bacteria, and that may have misguided you for infection. So disintegration of a cellular elements, especially in alkaline and hypotonic urines, though this might have to cause the disintegration of the cellular element by keeping the urine sample on a room temperature. Urine sample must be tested in the laboratory within 2 hours of a collection to get the correct results. So therefore, it is recommended that when you are collecting the urine sample for analysis, it must be processed within 2 hours. Otherwise, the uh, uh, the production of ammonia, the formation of crystals, the loss of ketones, or decrease in the glucose, oxidation, and bacterial proliferation and disintegration of cellular elements may cause to elevate or to change the results and misguide the uh, information. So therefore, the samples must be preserved. The preservation of the urine samples must be taken place in the refrigeration. So the refrigerators must be maintained at 4 to 6 centigrades uh, is the best general method of preservation of urine samples up to 8 hours. So you can preserve the urine sample for 8 hours by keeping this one at a 4 to 6 centigrades in a refrigerator. So following the chemical preservatives can be used to the 24 hours urine sample. So if you are want to preserve this urine sample for 24 hours, then you can use the chemical preservatives, which may have to save the sample and give a more shelf life to the urine without changing the results. So hydrochloric acid can be added. It is used for preservation of a 24-hour urine sample for adrenaline, noradrenaline, vinyl, vinyl mardelic acid, and steroids analysis. Whereas the a urine sample can be preserved by a toluene. It forms a thin layer over the surface and acts as a physical barrier for bacterial and air, and it is used for the measurement of chemicals. If the sample is being kept for 24 hours for a chemical analysis, then the toluene can be used as a preservatives, and then the urine sample can be preserved for 24 hours for analysis of the chemicals. Boric acid can be added as a preservative. Thiamol can be added to inhibit the bacterial and fungal putrefaction or proliferation. Formalin, it is an excellent chemical for preservation of formed elements. The formed elements can be even preserved uh, by keeping the urine under the formalin, mixing with the formalin. That can be the elements without the change. It can be preserved, and after 24 hours, up to 24 hours, the sample can be kept and analyzed. So it means that the fresh sample should be taken and immediately it should be processed for analysis of the urine to collect the right results or correct results. So the urine examination always been dependent on the three type of the examinations are being kept on the urine, and the urine analysis can be completed by three investigations. One is the physical investigation or examination, then the chemical examination, and microscopic examination. So this is known as a complete urine examination or urine DR. Urine analysis consists of a following measurements: microscopic. Macroscopic means a physical examination, chemical examination, and microscopic of the sediments or urine culture. Physical examination of a urine, examination of a physical characteristics like a volume of the urine, color of the urine, odor of the urine, pH, and specific gravity of the urine. The refractometer or reagent strip is used to measure the specific gravity. Physical examination for volume. Average 24-hour urinary output in the adults is 600 to 2000 ml. Again, depend uh, on the water intake. So the volume varies according to the fluid intake or water intake, diets, and climate. Abnormalities of the urinary volume are as follows: that might be the patient is suffering with a polyuria, means a urinary volume that's a 2000 ml in a 24 hours. So this is seen in the diabetes mellitus or diabetes insipidus. So the chronic renal failure or a diuretic therapy. So the oliguria, that means the urinary volume is more than 400 ml and within the 24 hours. So this is seen in the febrile states, acute glomerulonephritis, congestive cardiac failure, or dehydration. So anuria means the urinary output is less than 100 ml per 24 hours or a complete cessation of urine output. So this occurs in acute tubular necrosis, in shock, hemolytic transfusion reaction, or acute glomerulonephritis and complete urinary tract obstruction. Physical examination in a volume, the 1 to 2.5 liters per day normal. Oliguria, that's urine output is 400 ml per day. We are seen in a dehydration, shock, or acute glomerulonephritis, renal failure, or polyuria, that urine output is 2.5 liters per day. So seen in increased water ingestion, diabetic mellitus or insipidus, anuria, that's the urine output is less than 100 ml per day, seen in a renal shutdown. Physical examination for color. Normal urine color is fresh state is pale yellow or amber and is due to a presence of various pigment collectively called urochrome. So the colors can be changed as the colorless, that might be a dilute urine, diabetic mellitus or diabetic insipidus, or overhydration can cause the urine color without any color and transparent and colorless, whereas the red urine may be seen in a hematuria or hemoglobinuria or uh, porphyria or uh, myoglobinuria. The dark brown or black uh, urine can be seen in alkano, electrouria and melanoma, whereas the brown urine can be seen in hemoglobinuria and yellow can be seen in concentrated urine, or yellow, green, or green can be seen in a biliverdin, whereas the deep yellow with a yellow foam is seen in a bilirubin, whereas the orange or orange brown can be seen in a urobilinogen, whereas the milky white can be seen in a chyluria, whereas the red, orange fluorescence with UV light can be seen in porphyria. The physical examination color, normal pale yellow in color due to pigments, urochrome, urobilin, uroerythrin. So cloudiness may be caused by excessive cellular material or protein crystallization or precipitation of a non-pathological salts upon standing at a room temperature or in the refrigerator. So the color of the urine depending upon its constituents. So physical examination continued like physical color, colorless, diabetes, diuretics, deep yellow concentrated urine, excessive bile pigments, and jaundice. Physical examination in appearance, we have to see that the normal, freshly wired urine is clear in appearance. Foamy urine occurs in the presence of excessive protein or bilirubin. So the amorphous phosphates, white and cloudy on standing in alkaline urine, disappears on addition of a drop of dilute acetic acid, whereas the amorphous ureates, pink and cloudy in acid urine, dissolve on warming, whereas the pus cells, very grass of a turbidity, can be seen on a microscopy, whereas the bacteria uniformly cloudy do not settle at the bottom following a centrifugation. So it can be seen by a microscopy or a nitrate test. Whereas the other, the physical examination for other, the normal aromatic due to the volatile fatty acids and on long-standing ammoniacal decomposition of a urea forming ammonia, which gives a strong ammoniacal smell, foul offensive pus or inflammation, sweet because of the diabetes, fruity because of the ketonuria, whereas the maple syrup, like other maybe due to maple syrup or urine disease, or rancid tyrosinemia are characteristics of rotten egg udder. Whereas the pH of the on the physical examination that reflects the ability of the kidney to maintain the normal hydrogen ion concentration in plasma and extracellular fluid. So the urine pH ranges from a 4.5 to 8 pH. Normally, it is slightly acidic, lying between 6 to 6.5. So the tested by a litmus paper or a pH paper or a dipstick can even determine the pH of the urine. Acid urine, like ketosis, that can be observed in the diabetes, starvation fever, whereas the systematic acidosis, UTI infections, or E. coli or acidification therapy may have to cause this acidic urine. The physical examination continues. A specific gravity, it is a measurement of a urine density which reflects the ability of the kidneys to concentrate or dilute the urine relative to the plasma which it is filtered. So it can be measured by the urinometer or a refractometer or dipsticks. So the urinometer, it always for a specific gravity, fill a measuring cylinder with 50 ml of urine, then the lower urinometer gently into the urine and let it float freely. So let the urinometer settle. It should not touch the sides or bottom of the cylinder. Take the reading of Lg on the scale. Lowest point of meniscus at the surface of the urine, and take out the urinometer and immediately note the temperature of urine with a thermometer. So for every 3 centigrade increase or a decrease, you have to subtract 0.001 specific gravity from the readings. The physical examination of a specific gravity. The specific gravity, the refractometer can be used for a specific gravity, can be precisely determined by the refractometer, which measures the refractive index of the total soluble solids. Higher the concentration, total dissolved solids, higher is the refractive index. So the extent of the refraction of a beam of light passed through urine is measure of a solute concentration, and thus the specific gravity. The method is simple and requires only 1 to 2 drops of urine. A result is read from a scale or from digital display. So the physical examination of specific gravity can be performed by a reagent strip method, measuring the concentration of ions in urine, which correlates with the specific gravity. So depending on the ionic strength in the urine, and polyelectrolytes will ionize in a proportion. So this causes a change in the color of the pH indicators. That's bromothymol blue. The specificity from 1.001 to 1.040 is normal. So the specificity 1.001 is the osmolarity is 100. 1.01 is osmolarity is the 300. The 1.02 having a osmolarity of 800. The 1.025 having a 1000, and 1.030 having a 1200 specific gravity and the osmolarity, whereas 1.040 having a 1400 osmolarity. So increase in the specific gravity, low water intake, and diabetes mellitus or albumin urea or acute nephritis may have to lead to this condition. Decrease in the specific gravity or absence of antidiuretic hormone, that's a renal tubular damage. So fix the specific gravity. Uh, Isothermiurea is a 1.01. So the reaction and the pH. So pH is the scale of for measuring acidity and alkalinity. So the fresh urine is required for collect the estimation of pH. upon staining, and urine become alkaline owing to a loss of carbon dioxide and production of ammonia from urea. So the normal value ranges from 4.6 to 8. Urine pH depends on diet, acid balance, water balance, and renal tubular function. So the various methods for determination of a reaction of urine, one is the litmus paper can be used, pH indicator paper can be used, pH meter can be used, and the reagent strips test also indicate the pH. So the litmus paper, a small strips litmus paper is dipped in the urine and any color change is noted. So the red and blue, the pH indicator paper reagents are area is impregnated with the bromothymol blue and methyl red of an indicator paper strips is dipped in the urine and sample and the color change is compared with the color of color guide provided, so that may have to lead the approximate pH obtained. The litmus paper may have to only indicate whether it's acidic or alkaline. The pH indicator paper indicates the pH range, whereas the pH meter that having electrodes of pH meter is dipped in the urine sample and the pH is read of directly from the digital display. So it is used if exact pH is required. So the pH meter is the more accurate and a more exact pH can be determined or assessed from use of by the use of a pH meter. So reagent strips test, that's a qualitative test. It can also indicate the pH of the sample. The test area contains the polyonic polymer bound to hydrogen ions. So on reaction with the cations, the urine hydrogen ions is released, causing the change in the color of the pH. Yeah. So the acidic urine, if that may have to gives you the ketosis condition or a diabetic mellitus, starvation, fever, urinary tract infection by Escherichia coli, or a high protein diets may have to lead towards a urine in acidic condition. Where if the alkaline urine is, then there might be a severe vomiting, old ammoniacal urine sample, or a chronic renal failure, urinary tract infection by bacteria that split the urea to ammonia and protease, pseudomonas, and vegetarian diet may have to cause the alkaline urine. The microscopic examination of the urine can be performed that may have to a sample of a well-mixed urine, usually 10 to 15 ml is centrifuged in a test tube at a relatively low speed, about 2000 to 3000 rpm for 5 to 10 minutes, which produce a concentration of sediment, cellular matter at the bottom of the tube. A drop of a sediment is poured onto a glass slide and a thin slice of glass. A cover slip is placed over it and observed under the microscope. So under the microscopic examination of the urine, you can see a variety of normal or and abnormal cellular elements may be seen in the urine. Sediments such as the red blood cells, white blood cells, mucus, various epithelial cells, various crystals, bacteria, and casts can be observed under the microscope. Whereas the microscopic examination of urine abnormal findings for high power field that may be HPF for 400x. So the less 3 ultrasound, less than 3 ultrasound are more than 5 leukocytes, more than 2 renal tubular cells, 10 bacteria. So per low power field like the 200x, 3 hyaline cast or 1 granular cast, 10 squamous cells indicating of a contaminated specimen. Any other cast like RBC cast or WBC cast may be present, and the fungal hyphae are yeast parasites are viral inclusions. So pathological crystals like cysteine, leucine, tyrosine, a large number of the uric acid and calcium oxalate crystals can be observed under the microscope. Hematuria in the presence of a abnormal number of red blood cells in urine due to any of a severe possible causes like glomerular damage, tumors which erode the urinary tract anywhere along its length, kidney trauma, urinary tract stones, acute tubular necrosis, upper and lower urinary tract infections, nephrotoxins, WBC, in a high number indicates inflammation or infection somewhere along the urinary genital tract. So the red blood cells in urine appears as refractories, white blood cells. Cast like urinary cast are clinical aggravations of particles that forms the distal nephron, dislodge and pass into the urine. And urine analysis indicate the kidney disease. They form via precipitation of a term horse called mucoproteins, which is secreted by renal tubule cells. The microscopic examination of urine types of a cast seen, that is a acellular cast, that's a hyaline cast, granular cast, waxy cast, fatty cast, pigment cast, crystal cast, cellular cast like a red cell cast, WBC cast, or a epithelial cell cast. The common type of the cast, hyaline cast, are solidified and tame horse walls mucoproteins secreted from the tubular epithelial cells and seen in a fever, strenuous exercise and damage to the glomerular capillaries. Red blood cells may stick together and form a red blood cell cast, such as a cast of indicative of a glomerulonephritis with leakage of RBCs from the glomeruli, severe tubular damage. White blood cell casts are most typical for acute nephritis, pyelonephritis, but they may also be present. So this is the hyaline cast, the granular cast, red blood cell cast in urine, then the white blood cell cast in urine can be seen on the slide. So this is a variety of normal and abnormal crystals may be present in the urine sediments. So you can see the urine acid, the calcium oxalate, the uh, hypovals, calcium phosphates, or even triple phosphates, calcium carbonates, ammonia, um, or even bilirubin, and that may have a cholesterol or even a cysteine, leucine, tyrosine, or even these sulfa or a cyclovilla and the antiware. So this chemical analysis of the urine can be taken place. The chemical analysis of urine undertaken to evaluate the levels of the following components like protein, glucose, ketones, occult blood, bilirubin, urobilinogen, bile salts. So the presence of normal and abnormal chemical elements in the urine are detected using a dry reagent strips called tip sticks. When the test strips is dipped in the urine, the reagents are activated and chemical reaction occurs. The chemical reaction results in a specific color change. After a specific amount of time has elapsed, this color changes is compared against a reference color chart provided by the company or the kit. In a kit, these color charts are available, which has to be matched with the strips. So the dip strips method by chemical analysis of urine, you have to dip the strip into the urine and then you have to left for a few minutes and then see the change in the color, and that the change in the color can be compared with the given standards of the colors, which may have the readings, and on that particular read, the glucose, protein, ketones can be analyzed and determined. So this is the strips, standard strips, on which you have to compare your strip color. So the leukocyte can be made, and then the number can be determined. The white blood cells can be seen, and the urinobilinogen, protein, pH, blood, and the specific gravity, the ketone, and then the bilirubin and glucose can be determined by comparing the various ranges or various the readings can be measured, and that can have to give you the uh, amount of the protein, ketone, bilirubin, the blood, pH, and the protein present in the urine. So the proteins in urine detected by a heat, a coagulation, or a dip method, the urine protein come from the plasma protein and Tom Horse fall TH glycoprotein. So healthy individuals excrete 150 mg per day of a total protein and 30 mg per day of albumin. Plasma cell dyscrasis, multiple myeloma can be associated with large amount of activated light chain in the urine, which may not be detected by a dip method. So the light chains produced from these disorders are filtered by the glomerular overwhelm. So the chemical examination test for proteins, heat and acetic acid test principle. The protein are denatured and conjugated upon the heating to give the white cloud precipitate. Whereas the method is to take a 5 ml of a test tube, so fill 2 to 3rd urine and acidity by the adding a few drops of a 3% acetic acid of a urine is alkaline. So the boil appears position for 2 minutes, and lower part acts as a clouded. So if the precipitation or turbidity appears, add a few drops of the 3% of acetic acid. So the heat and the acetic acid test interpretation, if the turbidity and precipitation disappears on addition of a acetic acid, it is due to phosphates. If turbidity or precipitation persists after addition of acetic acid, then it is due to a protein. So the test is a semi-quantitative and can be graded from traces to 4 pillars depending upon the amount of the protein. So no cloudiness means negative. The faint cloudiness means traces that might be less than a 0.1 gallon per day, whereas the cloudiness without granularity is 0.1 grams per day, whereas the granular cloudiness is plus 2, that's 0.1 to 0.2 grams per day, whereas the precipitation and flocculation is 0.2 to 0.5 grams per day, where the thick and precipitation is plus 4, so it may have to more than 0.5 grams per day. The sulfosalicylic acid test, this is the principal addition of a sulfosalicylic acid to the urine causes the formation of a white precipitate if the proteins are present. Method is that take a 2 ml of a clear urine in a test tube, If a reaction of a urine is a neutral or alkaline, a drop of a glacial acetic acid is added. Add 2 to 3 drops of sulfosalicylic acid and 3 to 5%, and examine the turbidity against a dark background. So interpretation appears of a turbidity would persist after a heating indicates the presence of a protein. Reagents strip method, that's the principle of a reagent area of the strip is coated with a bromophenol, blue indicator, and buffer to an acid. So pH, which changes the color in the presence of a protein, the bromophenol coated strip is dipped in a urine. So change in the color of a strip indicates the presence of a proteins in a urine and in compared to the color chart provided for the comparison as in a standard, and then you have to interpret that one. So reagent strips, principle for a test of a protein, the reagent's area of the strip is coated with the bromophenol blue indicator and a buffer to an acid. So the pH which changes the color in the presence of a protein. The method is the bromophenol coated strip is dipped in a urine and change color of a strip and indicate the presence of a protein in urine and is compared with the color chart and provided for a semi-quantitative grading and interpretation. So reagent strip test is mainly reactive to albumin. If it is a false negative in the presence of a Benz-Jones proteins or a myoglobins or a hemoglobin. So the examination test for protein, the Haller's test method, take a 2 ml of concentrated nitric acid in a test tube, add the urine drop by the side of a test tube, interpret the appearance of a white ring in the junction indicates the presence of a protein. The glucose, the main indication of testing glucose in urine is detection of unsuspected diabetes mellitus or a follow-up of non-diabetic patients. So all the glucose filtered by the glomeruli is reabsorbed by the proximal renal tubules and returned to our circulation. Normally, a very small amount of a glucose is excreted in the urine that cannot be detected by the routine test. So more than 500 mg per 24 hours or 15 mg per DIL presence of detectable amounts of a glucose in the urine is glycosuria. Glycosuria results in the filtered glucose load exceed the capacity of a renal tubular reabsorption. So causes of a glycosuria, the glycosuria with hyperglycemia, the endocrine disease, diabetic mellitus, acromegaly, Cushing disease syndrome, or hyperthyroidism, pancreatic disease, or a non-endocrine disease, central nervous system diseases, liver disorders. So the drugs of adrenocorticotropic hormones or corticosteroids or thiazides, elementary glycosuria, the large storage glycosuria. After a meal, there is a rapid intestinal absorption of a glucose leading to a transient elevation of a blood glucose above the renal threshold. So this can occur in persons with a gastrectomy or a jejunectomy and in the hyperthyroidism. So the glucose tolerance test reveals a peak at 1 hour above the renal threshold, which causes the glycosuria. So the fasting and 2 hour glucose values are normal. The glucose, chemical examination of the glucose, the causes of glycosuria is a glycosuria without hyperglycemia that might be due to a renal glycosuria. This accounts of a 5% 5% of cases of glycosuria in general population. Renal threshold is the highest glucose level in blood at which the glucose appears in urine, which is detectable by routine laboratory tests. The normal renal threshold for a glucose is 180 mg per day, whereas the renal threshold is set below the 180 mg per day, but glucose tolerance is normal. So the disorder is transmitted as a autosomal dominant. Reagents strip method that can be used for the testing of a glucose. This test is specific for a glucose and is therefore prepared over the Benedict's or the Clentis method. So it is based on glucose oxidase and peroxidase reaction. The reagent area of the strips impregnated with the two enzymes, glucose oxidase and peroxidase and a chromogen. So the glucose plus the oxygen that in the presence of a glucose and the oxidase that that causes the gluconic acid, and that is hydrogen ion, hydrogen peroxide. So this has to lead to the hydrogen peroxide with a chromogen. That peroxide is in the presence of peroxide is the oxidized chromogen below plus the water produced. So the nature of a chromogen and a buffer system differs in the different strips. The strip is dipped into the urine sample and color is observed after the specific time and compared with the color chart provided. This test is more sensitive than the Benedict's qualitative test and the specific only for a glucose. Other reducing agents given a negative reaction. So this is the chemical analysis that is the evaluation of a proteinuria. Proteinuria on a urine dipstick. So the this currently quantitative by 24 hours. So urinary examination of a protein and albumin are a first morning spot albumin to a creatinine ratio that the microalbuminuria, the macroalbuminuria are non-specific range that might be a 30 to 300 mg per day or 30 to 300 mg per gram, whereas the macroalbuminuria that may be a 300 to 3,500 mg per day, and that might be a 300 to 3,500 mg per gram. Non-specific range can be a more than 3,500 mg per day and 3,500 mg per gram. So RBCs or RBC cost are the if you see that the consideration that the early diagnosis, essential hypertension, early stages in the glomerular nephritis, especially with the RBC and RBC's cost. So in addition of disorders listed under the microalbuminuria, consider the myeloma, associated kidney disease, check UPEP, that's intermittent proteinuria or postural proteinuria. Congestive heart failure or fever and exercise can lead to this condition. So nephrotic syndromes like diabetes, amyloidosis, minimal changes disease or FSGS, and uh, membranous glomerulopathy may have to lead this condition. So thank you very much. This is the last slide, which is concluding. Now I will dismiss this class, and then we have to lead towards another class. Okay, thank you very much for patiently listening this lecture.